evening, everyone, and welcome to yet another Facebook Live brought to you by Sanofi, caring to raise awareness of women's heart health. Thank you all for joining our first episode of Women and Their Heart. Are women more prone to heart attack? This is the key question that we're going to address today and talk around this subject. My name is Dr. Suren Thuraisingham. I'm your host and moderator for today, and also a cardiologist at CVSKL. Joining me here today is my colleague and brother here, Fazir, and one of our esteemed cardiologists who's at CVSKL. And on my left here is the lovely caring pharmacist, Miss Safura. Good evening, folks. Before we move any further, Ms. Safura, do share with us what role do you specialize in being a pharmacist and how you can help our patients who are more prone to a heart attack.
Thank you, Dr. Suren. Hello and good evening, everyone. My name is Safura, and I am honored to be sitting here together with our esteemed consultant cardiologist from CVSKL, Dr. Suren and Dr. Fazir. So, to answer your question, as community pharmacists, we play a role in educating and counseling our patients regarding prevention and management of various health diseases, including heart disease. So we're able to provide educational materials through screening and monitoring of conditions such as blood pressure, blood cholesterol levels, and from there we are able to provide interventions in areas such as smoking cessation and lifestyle modifications, and maybe some medicines counseling for adherence and compliance. So my role in cardiovascular since is, of course, can't be compared to our consultants here, but being a more accessible option to the public, anyone who is concerned about their health condition and would like to get an advice from a healthcare professional is welcome to walk into any pharmacy for a chit chat.
Well, that's very useful to know, right? Yeah. Good to know that sometimes, when we write our prescriptions and we give our patient that script, we know that it's just, we try and do our best to communicate the need for these medicines. But it's nice to know that there's follow-up, a few hours later or a few days later when they actually come to the pharmacist and make that bold step of buying the drug. So it's really reassuring to know that this also goes on after we see the patients, right? And being a woman yourself, is it true that women are more prone to heart diseases? What do you think?
So for years, right, both the medical community and the public has regarded heart disease as a man's disease. But this, in fact, has been proven to be false. Anyone with the right risk factors and family history of cardiovascular disease is at a risk of getting heart disease. So, in fact, around the same number of men and women die from heart disease each year, and women are more unlikely to survive from their first heart attack. And at a higher risk of getting stroke.
Absolutely right.
This might be perhaps due to women being generally older when they get their first heart attack, because estrogen seems to provide women with some kind of protection against unhealthy levels of cholesterol. But this is only until menopause, which when estrogen levels drop and high levels of cholesterol becomes more likely. So other than that, certain disease that affects only women, such as pregnancy, polycystic ovarian syndrome, and endometriosis, may increase risk of women getting coronary artery disease, which is the leading cause of heart attack. So other than that, women can also develop high blood pressure from taking some medication, such as hormone birth control pills.
With this breadth of knowledge as a pharmacist, that's really good. And maybe, there's a much greater role for picking up people who are not aware of their own situation. And, for us, screening is an area that is very important to make people aware that, that they are not actually as safe as they think they might be. And people go to the pharmacist far more often when they come to hospital for health screening. So I think, if pharmacists can play their role in educating the public about these risks and screening for these things, we work complementary in that manner, right? So Fazir, what's your take on women's risk of heart disease and all this?
Yeah, I think that's very pertinent. I think as what our pharmacist said just now, I think we always think like heart disease is a man's disease.
Yeah,
right? But it's actually not. So I think if you look at all the statistics out there, even the Malaysian statistic that heart disease is the leading cause of death for men and for women.
Yeah.
And I was actually doing some research as well just before I came here. So I was looking at the age group. So below 55, you would see a predominantly male. So maybe like say 70% male, 30% female. But after 55 or after 60 years old, like she was mentioning about menopause, actually the rate of female having heart attack is double than male.
Yeah.
But somehow we always think that heart disease is a male dominated thing and all that. So so it's very important, I think, the awareness, and that's where you come in as well, the community, the link between community and hospital as well, because you have more outreach to patients. They come and seek advice. So that's where we complement each other, I think.
Absolutely,
Yeah, so I think heart disease is very important. I think the rate of mortality for heart disease is more than cancer in female. I mean, it's like 7 times more than cancer for breast cancer as well. So I think we need to be aware that male and female are exposed to this coronary heart disease, and I think we need to take steps to make sure that we don't or prevent from getting heart disease.
I mean, I think the point that many women really are mostly fearful about cancer, right? And cancer is the preoccupation, especially breast screening, cervical screening. And heart disease is always somehow put on a lower shelf in priority. But as Fazil just pointed out, the outcomes in postmenopausal women is really, really bad with coronary artery disease, all right, now, our Fazil here is a keen cyclist himself and exercises regularly, unlike me. What do you think we are still, what do you think about exercise and the role of heart disease and the potential harm of exercise?
Okay, so I think number one, exercise is very important. So we all need to exercise or try to find time to exercise. The guideline says that 150 minutes, at least 150 minutes a week of moderate intensity. So
you do 150 minutes a day, isn't it?
I don't have time. But anyway, so for example, last Thursday, I went cycling in the morning at 7 in the morning. So I have to wake up at 5:30 in the morning to get everything. So you really have to chop your hours and try to find that small slot where you can try and do some exercise. Yes, exercise is very important. So try to do 150 minutes a week of moderate intensity. But saying that also, I've got a few patients who came into the clinic this week because they are getting ready for the Desaru Ironman in July. And one of them came into my clinic, is super fit, very fit. He can cycle and run a marathon. Blood pressure, high, 160 over 100, and his cholesterol, 7. So just because you can run, you can do the marathon, you can swim 2 kilometers, but please make sure that you check your health, your own statistics, or do your blood test, check your blood pressure and your cholesterol level, because you may look very fit and you can do a lot of exercise. And well, being a weekend cyclist myself, I have had a few friends who had a heart attack while cycling. And it's always a bit scary. So one of our colleagues, he basically at home, and he's a very keen cyclist. He cycles about 2 or 3 times a week. He initially thought he had a gastric, sort of like a gastritis pain. And the first thing that we do in Malaysia, or most people, they say, okay, it's probably just gastric, and goes to bed. So he tries to sleep it off. At 3 in the morning, he started to sweat, shortness of breath, and it was a proper heart attack. So I think I think you can exercise, you can go to those kind of distance. That if you want to do Ironman, you can, but please make sure that you do your health checkup and make sure that you are protected before you do all these extreme sports.
I mean, I think everybody should know their risk status. Okay, your own personal risk status, which varies from individual to individual, needs to be established by the time you reach 30 years old or something. We've talked about this before in all our health screening talks. But exercise does not, indemnify you from heart attack or heart disease. So if you've got a family history, especially premature heart disease, father, mother, or sibling below the age of 55 in the case of women, or 65 in the case of men in the family. Sorry, the other way around, 65 women and 55-year-old men. Please get yourself checked out, especially if you're going to embark on some vigorous exercise routine, because plaque rupture can occur during that time. And we'll talk about the plaque and all that issue later. But everybody has to establish their own personal risk status. Do a checkup, as Fazir has said, check your cholesterol, your blood pressure, establish these parameters. But across the board, if everybody indulge in regular, moderate exercise, you're going to be pretty safe. All right. All right. Another question for both of you, really.
Mhm.
Do younger, physically fit women like you need to worry about heart disease?
Actually, heart disease affects women of all ages. So, of course, your risk of getting heart disease increases as you get older. But for younger women, the combination of smoking and taking birth control pills increases your risk of getting heart disease by 20%. So, of course, things like overeating and sedentary lifestyle will increase your risk of getting heart disease, but these are not the only things. So, as you have mentioned before, if you have a family history of heart disease, if you have someone in your family who has had a heart procedure done on them, it might be wise for you to get your blood
checked,
blood cholesterol levels and blood pressure checked regularly, even as early as in your 20s. So even if you are fit, you still can't ignore your genes and other cardiovascular risks such as obesity, high blood pressure, and because these are still significant.
Suren, I had a patient. She came to me because she did a stress test in somewhere else. And she's a 46 years old marathon runner. Husband went abroad a few months ago because he was doing Ironman. Super fit, super fit. And I saw the stress test is highly, significant. But I could not believe the stress test. So I did a CT scan, and it was 90% stenosis. And sometimes you can, if you look at the person,
definitely family history. Yes.
Yeah, family history.
Family history.
She's got a family history.
Sure.
So
there's always a reason.
Yeah.
Nobody gets severe heart disease out of the blue. There's always a reason. It's a question of establishing that. Yeah. So that's scary and
it's scary and
sobering and
it is.
all those things.
It is. And like you say, I think everybody needs to know their own risk profile. I mean, you need to know where you stand with your family history, or in Malaysia being the highest, obesity rate, diabetes, all this. But we have all this, good food and high cholesterol. So we really need to look after ourselves.
Yeah. I think also there's a significant race difference in our population here. Like in under 40s, Indian women have an 8 times higher than Chinese women rate for getting heart disease. And the disease does vary significantly between the 3 major races here, especially, and Indians are particularly high risk, Okay, this is an important thing. Are there any female-specific disorders that increase a woman's risk of heart disease?
Well, I guess if you talk about just female specific, I think autoimmune tend to occur more in females. So when you talk about, rheumatoid arthritis, lupus and all that, basically you have a high inflammatory state, and that maybe predispose you to having earlier sort of atherosclerotic process.
Absolutely.
So that's probably one. And the other one, maybe quite common, is polycystic ovarian PCOS. Then you might have a high sugar state and a high cholesterol as well. So I think those things, first of all, you need to have a checkup. You need to have a checkup to make sure that you have these kind of conditions. And when you do, and as our pharmacist was mentioning about menopause as well, I think some do go early menopause, or you need to have some form of hysterectomy. That can alter your estrogen hormone balance as well. So I think that can lead to early atherosclerotic process in females.
And sometimes the drugs like steroids, which you guys dispense on our behalf, they also can increase your risk of coronary artery disease, atheromatous disease, hypertension, diabetes, may also be the drugs that are used to treat these conditions, and Fazir is talking about, right? And of course, pregnancy pregnancy-induced hypertension,
Yes.
gestational diabetes, preeclampsia, all convey a significant cardiovascular risk many, many, many years later. And that's something that's been coming out recently, right?
Yeah.
If you have preeclampsia, your risk of coronary artery disease is about 6 times higher in the ensuing 15, 20 years
Right.
after that. So this is all really worrying, and obviously female specific, right? Right. Now, there's a lot of talk that, statins, right? Statins, which we all love a lot, and the public at large seem to dislike. But there's a question mark about the risk of diabetes when you go on statins. If a patient was to ask you, brings a prescription from Fazir for statin, and the guy is like nervously giving it to you, ini boleh menyebabkan kencing manis ke? What do you want to say, Safura? Are you aware of the?
For this question, maybe Dr.
Yeah,
Alfazir
all right.
is more.
Okay. But I think that's a very important question.
Yeah.
And sometimes you get a lot of stuff from the social media. And they may have heart disease, or they may have a stroke or heart attack. And then you say, kenapa tak makan ubat? And they say, oh, because I'm worried about diabetes. I'm worried about memory loss and all this. So I mean, there's
Erectile dysfunction,
and all that,
libido, all
Yes,
these nonsense things, right?
Correct. So number one, well, essentially, generally, it's not true. I mean, it does not cause diabetes, but maybe in a small population, maybe up to 10%, it can raise up the sugars a little bit. But most importantly, the but is that they have done so many studies, and you look at the risk and benefit. So you don't take statin just because it's in trend, or because it's free, or because you can see a nice pharmacist in the clinic. It's because the benefit of statin way outweighs the risk, and there is a small rise in sugar for certain patients. But if you look at the mortality risk, the risk of having cardiac events, a heart attack or stroke, the benefit of statins in controlling cholesterol in this population who are high risk, who's got probably a heart disease or very high cholesterol or very strong family history, the benefit of this definitely outweighs the slightly increase in sugar in this very small population.
I mean, they say the statins unmask latent diabetes anyway. That's going to happen anyway. And we know that in pre-diabetes, already statins have a 20 to 30% reduction in event rate. So it's a no-brainer decision to be concerned about sugar elevation when you've been taking a statin. Right? How does diabetes, type 2 diabetes in particular, change the risk for other diseases, including cardiovascular disease?
Yeah, I mean, once you have diabetes, having diabetes is not good,
Yes, obviously.
And it affects everything. So the problem with diabetes is kind of like lifelong. It's like your wife. It's with you all the time, and you might have good control for 20 days, but you might have lapse, and you might have a lot more sugar.
Lapse?
Yeah. Sometimes, once in a while, have chocolate cakes, but then your sugar goes up, and over time, it causes microvascular and macrovascular. So it causes changes in your eyes. So basically, the problem with diabetes, it affects everything, from your brain to your blood vessels, to your heart, to your kidneys, to your legs. So diabetes is a process where it really alters how our body, the process of atherosclerosis, a process of inflammation as well. So but the good news is that we can manage better diabetes now by having a good lifestyle. So if you have a good, healthy lifestyle, reduce sugar. So one of my things in the last 3 weeks is no sugar. So you completely reduce sugar, and you start to actually enjoy.
I can see the vast improvement.
Slightly, yes. But on a serious note, I really enjoy. And now, if my wife put a bit of vanilla in my coffee, it was very sweet. Because suddenly your whole sweetness level just completely changed. And when you look at the fridge at night to have supper, you're like, oh, I can't take this, and suddenly you can't.
Oh,
there's a lot of things that you can't eat.
Respect, yeah.
But I have to, So anyways, yeah. So it's important to have a good quality of lifestyle, because everything that we have, or nearly every reward mechanism that we have, is all sugary based. have a celebration for a birthday, is a birthday cake.
Yeah.
You know, it's all that. So I think for diabetes, unfortunately, you have to have a more stricter control on your sugar intake, on your carbohydrates. Healthy lifestyle. So when you do a lot more exercise, you burn all the calories and sugar. And luckily, also in diabetes, and I'm sure you see that as well. We have so many good medications now as well. So if once you're
fantastic drugs,
diabetic,
yeah.
it's no longer insulin. You know, when you say diabetic, the first thing they say is, oh,
No,
kena cocok.
yeah.
You know, but now really times have changed, and you see really fantastic medications that really change the prognosis and outcomes.
And these drugs not only help diabetes, they help heart failure, they help hypertension, they help kidneys,
yeah.
they help everything, right? So
Yeah, it's
this is
amazing.
wonderful.
So that just tells you how bad sugar is.
Yeah,
you know?
absolutely, yeah. Yep, okay. Right, I think anything you want to ask us, Safura? I mean, from your perspective as a pharmacist, anything you think maybe us doctors should be doing better or could be delving deeper into?
I'm just wondering whether there are differences in how CVD medications are being prescribed for women compared to men.
That's a very good question.
I got no gender bias, so the same.
Wow, that's a perfect answer. Yeah, right. Actually, I see no difference in the way we should tackle these. The targets are the same regardless of gender. So blood pressure targets need to be achieved, and the drugs we use are pretty much the same. And really, I think
no difference.
there's no gender difference.
Because they present differently in men compared to women, right? Like,
Actually, that's a good point. You know, one of our friends, she had sort of back pain. So she told her husband, "Oh, can we go for a massage on a Sunday afternoon?" Because she said there's a bit of neck pain, back pain, and half an hour later, while they're changing to go for a massage, she started to have sweating. She actually had a heart attack.
Yeah.
And so I was looking up some of the data as well. Although chest pain is still typical in female, but having back pain, the pain between your scapula, is 7 times more common in females compared
Really, I
to
didn't
men.
know
Yeah.
that.
So
Wow.
back pain and then nausea and vomiting. So the only problem with this is that now every female's got back pain. They're going to come and say, I got a heart attack, you know. But just be aware. I mean, if you do have some form of back pain or chest pain, I think you need to check it, have a checkup now.
Right.
But just be aware that it can be a bit atypical, like you say, in female.
I mean, there's one of the clear differences between women and men is the nature of their coronary disease, and especially Indian women. Again, they tend to have a lot of diffuse atheroma compared to Chinese and Caucasian races, right? Malays is kind of in between two, and so they tend to present with much more severe diffuse disease. And this thing called Syndrome X that the Western countries talk a lot about, where women seem to have up to 20% of women presenting ischemia have normal coronary arteries. Is that your experience here?
Yeah, I mean, sometimes it's very hard to prove or disprove because it's like your coronary arteries is quite well, but we feel like a microvascular disease and small vessel disease. So, and that's where I think history taking is very important and trying to tease out whether this is actually a cardiac disease or something else as well.
Muscle pain.
Correct.
Exactly.
So it's not easy to differentiate. Yeah.
It looks like we got some questions that have come to us from our audience. Right. Let me see. Right. Let me ask Fazir. At what age should we start doing heart screening?
I mean, looking at the lifestyle and I mean, of course, I would advise anyone above 40 to start. But looking at how obesity in Malaysia and risk factors, I mean, I think there's no harm doing it earlier. So once you're 30s, you want to have a health checkup, you can, so at least to know where you lie in this baseline. Some people, they're not even aware that they're diabetic or they've got hypertension. And we have seen young diabetic, young hypertensive patients as well. So it's, I mean, you can start rather early, know where you belong in the scale. And if everything is normal, then you might want to do a more regular checkup once you're above 40. But I will start fairly early because we're seeing how our pattern of disease
Yeah.
in Malaysia is very early.
I would definitely say at least a blood test,
Yeah.
maybe even at 21,
Yes.
a blood test.
Yeah.
Forget all the other tests,
Sure.
a blood test. And if one of their parents has heart disease below 55, if they are male, or 65 if they're female, then the risk is about 3 times higher for you. If both parents have heart disease below 55 and 65, respectively, your risk is 6 times higher. So I think if that's the situation, then from 20 years old, you better establish where you are with cholesterol. And I would even say if your cholesterol is really high and your lifestyle has been addressed, you need to start medication. And so screening, I think, as Fazir says, maybe if you are otherwise healthy with a good profile, up to then 40 is probably for more detailed tests. That's a good age. But if you're in any way high risk or have a family history earlier.
Yeah.
Yep. Another question is, being tested positive for COVID-19 will increase your risk of heart disease in women. Right. So basically, if a woman gets COVID-19, will that increase the risk of heart disease?
Okay, so interesting question. So I think there's a recent paper in, I think, New England that said that if you have COVID-19, you are increased for heart disease, so related to heart disease, commonly is palpitation, and also irregular heartbeat or atrial fibrillation. So I think that is probably the most common thing that we have seen.
Pulmonary embolism.
Correct, yes. But thankfully now, I mean, during the peak of the pandemic, we had so many patients, right, coming in with palpitations. I mean, to a point where we had the young ones and the elderly, everyone seemed to be coming with palpitations.
And also after the vaccine.
Correct.
Yeah. Usually the first week.
Yes.
Maximum 2 weeks, right? Yeah.
Some of it, I mean.
Some have long COVID.
Correct.
Of course.
Correct. So, so I think palpitation and also atrial fibrillation is probably the most common cause. But heart disease itself, I don't see that many. Not much, right?
I don't think there's an association with coronary artery disease so far established.
So far.
Yeah.
I mean, we don't know about long term. I mean, we are also just learning this whole COVID-19. But the palpitation is the one that we see most commonly.
In the pharmacies, which is where everybody went for Panadol and, ubat sakit tekak and all that, were there a lot of complaints that they had palpitations to pharmacies? Were they asking for ubat deba-deba?
If they are coming for with palpitations, we would definitely refer them to doctors.
Right.
Those are not
among
those the
simple
symptoms
things.
that we treat in a pharmacy.
Yeah. Great. I think you all did a great service to the community as pharmacists during this time, because a lot of us were hospitals people were not allowed to come into hospitals, and so. Any other questions? Is it true if we take diabetes medication, that diabetes won't cause heart disease? Anything, comment on that?
So I think the importance of taking your medication for diabetes is in controlling your blood sugar level. So as I have mentioned before, one of the risks of getting cardiovascular disease is actually high blood sugar level. So it's not, your heart disease doesn't come from taking the medication, but it actually helps in preventing you from getting heart disease in the future.
Yeah. All right. If someone eats a diet low in saturated fat, can that lower the risk of heart disease?
Actually, regarding diet and reducing your risk of heart disease, in a pharmacy, I would usually just give a simple answer of to follow the Malaysian guideline of healthy eating, the suku separuh way. So it's a quarter, half, which your quarter should be protein and a carbohydrate, and the half should be consisting of fibers your veggies and your fruits, because fruits actually fibers actually is harder to digest, so it doesn't spike your blood sugar level. So this helps in managing your heart disease as well.
Yeah.
So it's not just eating food low in saturated fat. It's not as simple as that. There's a good cholesterol and bad cholesterol. So usually we would say we want the good cholesterol. So some people go for the Mediterranean diet because there's some research that has been shown it can reduce the risk of getting cardiovascular disease. But for us Malaysian, you can just go for the simple suku separuh diet.
Have you come across any mama stalls doing Mediterranean diet recently?
Not the usual mama stall that I go to. But
Sorry.
but it's a good point. So because I'm into this low sugar diet for now, well, 1 month now, I've been looking at stuff to eat and fruits. Because what happened the last maybe 1 year or 2 years, every after dinner, we will have a fruit, but mangoes and all this. So then I check how much sugar in a mango. It's about 60 grams of sugar. So if you look at the sachet of like coffee sachet, right? That's like what? That's like so many sachets of sugar. Yeah. So that puts so like I think guava is okay, papaya is okay, but there are certain. So when we say fruits, you cannot have a generic fruit because fruit got different amount of sugar.
Right. Yeah.
So now, unfortunately, my mango has to be on special occasions. It's okay lah, but papaya is okay lah. So papaya, grapefruit, all this. So I think we need to be aware of food as well.
That's a good point. Good point. Yeah. People with pacemaker implants have a high risk of getting other heart disease. Wow, that's
very technical.
That's a very technical question. Yes.
Maybe you can answer that.
Well, first of all, I guess the question is why did they need the pacemaker in the first place? Whether that was a manifestation of like coronary artery disease or cardiomyopathy or some other illness. So I think that would be the most likely association. I can't imagine pacemakers causing heart disease apart from if they are the wrong type of setting, causing, diastolic heart failure, or if it's too fast or something causing some tachycardia but these are small things and definitely not everyday issues. So pacemaker implants are unlikely to cause any serious heart disease. More the other way around, the heart disease manifesting with the need for a pacemaker. Yes. Okay, I have another question here. I'm 37 years old, obese with a BMI of 32. Recently did cardiac screening and my blood pressure was 126/85. Blood tests were all normal. ECG was normal. I have no history of a family history of heart disease or diabetes or hypertension but my chest X-ray detected cardiomegaly. Cardiomegaly means the chest X-ray on the X-ray is more than 50% at its widest point for the whole compared to the size of the chest. Why am I getting cardiomegaly? Thank you, doctor.
Okay, thank you very much. Okay, so actually that is also another good point. I mean, sometimes we look at the chest X-ray report and they say mild cardiomegaly, and they say, "Doctor, have I have an enlarged heart?" Yeah. How? So actually, most or a majority of patients do not have cardiomegaly or an enlarged heart. I mean, it's just the way of the X-ray beam, especially when you're a bit more obese as well. So the beam goes outwards. So sometimes it looks a little bit bigger on the chest X-ray. So majority of people have a normal size heart, but if there's still a concern, then we will examine and we'll probably do an echocardiogram. So the echocardiogram is like an ultrasound of your heart. And that ultrasound is going to be able to check your LV dimensions. And most of the time, when they say mild cardiomegaly, hopefully it's just a normal heart.
Yeah.
But of course, there are patients who can have cardiomegaly, and then we have to examine why you have cardiomegaly in that sense.
Yeah. So I think the chest X-ray is a crude tool for determining the size of the heart. Especially if it's only slightly enlarged on the X-ray. So I wouldn't get too worried, but if it's really large and you're concerned, you need to go and do an echocardiogram, whoever this is. Do we have to monitor our heart rate while exercising? This is a really good question.
Yes, fantastic.
And you're an exerciser, so tell me.
So I do feel so as well. Yes.
I don't feel so.
Well, okay.
Right.
But-
You're an exerciser,
Yeah,
so
so-
maybe you can elaborate.
Yeah, because if you want to exercise properly, you need to be objective about it. So I mean, so when we cycle or if you run, we have like a heart rate monitor across our chest, or we have a heart rate monitor watch as well. And if you're going to cycle like 3 hours, and you need to know what's your target heart rate. Okay, say that if you're 50 years old, so 220 minus 50, that is your target heart rate. That's 100% of your maximum heart rate. And if you're going to exercise in a long distance, you try and keep it between 70 to 80%. So a nice heart rate when you exert on an endurance, it's probably about 140, 150. And occasionally you can push up. So sometimes what I have realized when you wear the heart rate monitor and when you cycle, see you go up the like say Fraser Hill. And sometimes occasionally you see someone younger than you and then you try to follow them, right? And you look at your heart rate monitoring, it's 180. So without you realizing it, you're really pushing it so hard. And because it's going to be another 30 kilometers, you don't go at 180 for another 1 hour. So then you slowly pace down your, bring it down a bit lower, reduce the cadence and all that, so that you try and bring it back to 140, 150. And with time, once you get healthier and more stamina, you can go further and maybe as fast as this young chap, but maybe at the height of 140, 150, which is much safer. So that's where I feel the value is that you can know where you are in this form of exercise, because there are people who I've seen people who's not done much cycling and suddenly they want to do Genting Highlands.
Okay, but is there any proof that monitoring your heart rate is going to determine whether you're going to drop dead on a
No.
bicycle or whether you're going to live longer in your life by hitting certain targets? I mean, some people become so obsessed about this, and they feel that they're unable to hit a certain number. Is there something wrong with them and all that? But all we know that for optimal cardiovascular health benefit, you just don't have to. You just do moderate exercise, brisk walking for 150 minutes a day, a week, and you have maxed out on your health benefit from cardiovascular system.
Correct.
Yeah.
But the only problem now is that people are. I mean, I've seen so many people who's not done, like especially during the MCO time. I've seen people who's not cycled before, and they want to do 180 kilometers. They want to do this. They want to do that. So instead of becoming sensible and say let's do moderate exercise, 150 minutes, they suddenly go to like 5 hours cycle.
Sure.
They cycle from KL to Malacca and Malacca back.
Yeah.
So so that's where I think if you want to go at that kind of level, then it does give you a reminder. So for me, it kind of reminded me, oh my God, it's 180. So let's bring it down a notch down.
Okay.
I mean, so in that sense, it helps.
I don't think my heartbeat's ever gone above 120. So maybe that's why.
You're very fit.
I doubt that. All right.
Do you exercise?
Moderately.
Right. You run or cycle?
I just go to the gym sometimes.
Go to the gym.
Very good.
Do you monitor your heart rate?
No, I don't.
You don't?
No,
Okay.
I don't actually.
Okay.
I just make sure that I finish the target of my exercise.
Yeah,
every day.
that's good. That's sensible.
Yeah. I've heard people died while exercising. Well, so that's the point, right?
Yeah.
You could. I know fellas who've exercised and they finish and they're sitting down having a teh tarik and they collapse, right? So I mean, okay. Recently I did a blood test on CRP and the result is 5 and I'm 53. It's a good question. Fazir.
Okay, or CRP or HSCRP, so high sensitivity CRP. So there is, CRP can be raised due to many reasons too. I mean, sometimes you can get...
In fact, most commonly not for the reasons that people fear, right?
Correct. So, I mean, so the problem with HSCRP or CRP, it's a reflection of inflammation of some form, and we can get it due to a fall, can get it from infection and many things as well. Although there has also been evidence that the process of arteriosclerosis can be partly related to inflammation. So if you keep having a high HSCRP, you may have some form of background high inflammatory rate, but I think this is something that is still quite early days, right?
Yeah, absolutely.
I
mean, I don't think in our practice we majorly blown away by a CRP making a decision about the patient. We still look at the traditional risk factors and the absolute LDL level, the HDL level. The CRP is neither here nor there.
Yeah, correct.
Personally speaking, anyway. Yeah. Women with polycystic ovarian is more prone to cardiovascular disease. Well, Safura, you did mention this earlier. I think there's a clear correlation there. You want to say anything more about that, or do you think?
So, polycystic ovarian syndrome, or more commonly called as PCOS, is when a woman has an enlarged ovary. So there might be small cysts on the ovaries, and this will come with insulin resistance, metabolic syndrome, and obesity. So those are the risks for heart disease as well. So what they can do to prevent heart complication is to control their blood sugar levels by eating healthy and then taking up exercise, all those.
Yeah. Okay, good. Any other questions? All right. Women are less likely than men to have coronary artery bypass surgery, perhaps because women have less obstructive disease or smaller arteries or small vessel disease. Is it true?
So I think, what a question. So basically, women are less likely than men to have coronary bypass surgery. So bypass surgery means open heart surgery. And it's probably true because women, they tend to present much later as well. So possibly, when you present quite late, the risk for open heart surgery might be a bit too high, or they may have more discrete lesions as well. So I think it's multifactorial. It's so I don't think it's any gender bias here. I think maybe they present much later. So sometimes the risk of doing a bypass may be a bit higher than men general.
In compared to Caucasians, Asian women, especially South Asian women, have about a 30-40% higher likelihood of having left main and triple vessel disease than Caucasian women. So that's well known. Again, I think it's insulin resistance, metabolic syndrome, diffuse atherosclerotic disease. So they end up having bypass more often. But their target vessels are smaller, and the hearts tend to have more fat, and it makes it more difficult for surgery. But I think that's the case. How will we know if my condition is getting worse or progressing? I think that's a bit non-specific, right? Let's skip that one. Will I need to take all the medicine I was given after my heart attack for the rest of my life? Discuss with pharmacists. Yes. Good for your business.
Usually heart disease is a lifelong condition. So you are most likely will have to take your medication for a long term, unless you have been advised not to by your doctors. But generally,
I think that's very important. In fact, in cardiovascular medicine, 90% of our medication is lifelong. There's no such thing as a course of diabetic treatment or a course of blood pressure treatment or a course of statins or whatever. It is lifelong. Of course, if you're one of the rare people who completely turns your life around and loses a lot of weight and exercise, then maybe you can shed diabetes, or especially mild diabetes or hypertension, right? But generally, hyperlipidemia is lifelong. Double blood thinners, yes, for the first year after a heart attack, you will need double blood thinners, but after that, a single antiplatelet would normally suffice, but otherwise it's lifelong. I think there's one thing that maybe pharmacists could educate patients more about is vitamins and supplements, because generally as cardiologists, we don't see much of a role for them. But a lot of patients end up going to pharmacies and buying lots of vitamins and supplements, which I think it's important that they understand these drugs have very little health benefit, and they should not avoid their proper pharmaceutical prescribed drugs. How is women's heart disease different from men's? We've already talked about this, I think. Any other questions? All right. If anything else, either of you want to add or any message for our audience today, take-home messages?
My side, I would advise for everyone to know your risk factors for heart disease and know how you can manage them. For example, you have to take in charge of your health conditions such as diabetes, high blood pressure, high blood cholesterol level by doing regular screening. And remember that your friendly neighborhood caring pharmacist is always available for you to offer health screenings and have a consultation regarding your health.
All right. Fazir, anything else you want to chip in?
Well, I think from the topic today, I think, so men and women have, you have to look after yourself, and don't think that heart disease is a man's disease. So
Absolutely, yeah.
please look after yourself, and you can start at an early age because I think prevention is still key. So what we described, I think it's a complementary between specialists and community pharmacists, and also for you to have to keep a healthy lifestyle, so that we can have Malaysian who sports bersukan and have a good diet, so that we don't have such high diabetes, high heart disease that we see. It's very frustrating when we see patients who are so young and come in with heart disease, right? So let's try and keep a healthy lifestyle.
I think I'd like to thank Safura and Fazil for this very enjoyable discussion and highlighting these key topics we've covered today. So for all the audience, thank you for your patience and for indulging us during this little chat. And we ask you to please join us for a July session when we're going to discuss acute coronary syndromes and the medications and the management of this condition. Thank you and have a good evening.